You see an influencer vlog their afternoon, right? They grab an iced coffee, pop into a brightly lit clinic, and film themselves getting a quote-unquote lunchtime peel. It looks incredibly breezy.
Oh yeah, it looks completely casual, like a spa trip.
Exactly. But what they don't film is the actual clinical reality behind that procedure. I mean, they definitely don't mention the medical guidelines stating that certain chemical face peels actually require the patient to be hooked up to a cardiac monitor.
Right, because the acid literally melting their skin could trigger a fatal heart arrhythmia.
It's wild. And that stark juxtaposition is exactly why we're doing this deep dive into the clinical guidelines on non-operative facial rejuvenation today. Especially for you listening, if you're a plastic surgery resident preparing for your board exams, like the FRCS.
Yeah, you have to look past the commodified, spa-like aesthetic. The medical literature explicitly warns that treating these non-surgical therapies as, risk-free or complication-free is entirely fallacious.
Right, these are serious medical interventions. We're talking about treating photoaging, severe pigmentation, and deep structural wrinkles. So let's just get straight to the point. We're going to cover everything from stripping away skin layers with chemical burns to injecting structural gels and finally paralyzing facial muscles with one of the most lethal biological toxins on Earth.
It's a heavy lineup.
It really is. So let's start with the surface canvas, resurfacing the skin using chemical peels. For exam purposes, how exactly do we categorize the depth of a chemical burn?
Well, we basically divide chemical peels into 3 distinct depths. So you have superficial, medium, and deep. And remember, a chemical peel is the intentional, controlled destruction of the outer layers of the skin.
Okay, so the biological goal is basically to obliterate the damaged tissue so the body is forced to replace it.
Exactly. You want new cells with a more even texture and color. To really understand the depth, you kind of have to picture the skin like a mattress.
Okay, a mattress.
Right, so the very top sheet is the epidermis, that's your protective barrier. Underneath that is the papillary dermis, and then beneath that is the thick structural bottom layer, the reticular dermis, which houses all those deep collagen springs.
Right, so a superficial peel, those so-called lunchtime peels, they're only targeting that top sheet, the epidermis.
Hmm.
The clinical guidelines mention using alpha or beta hydroxy acids like glycolic or salicylic acid or Gessner solution.
Yeah, exactly.
But the text points out a pretty crucial chemical requirement for alpha hydroxy acids. It says they must be actively neutralized at the end of the treatment. Why can't you just wipe them off with a towel?
Because you're applying an active acid to living tissue. And alpha hydroxy acid drastically lowers the pH of the skin to dissolve the bonds holding those dead skin cells together.
Which sounds good for exfoliation, but
But if you don't apply a strong base, like sodium bicarbonate, to chemically neutralize that acidic reaction, the acid just continues to eat downward. It won't just magically stop at the epidermis.
oh wow, so it just keeps burning.
Yeah, it will breach the basal layer, which is the dividing line of the skin, and cause entirely unintended scarring.
That's terrifying, which I guess brings us to medium peels.
Yeah.
Those use trichloroacetic acid, or TCA,
Yeah.
at like a 20 to 35% concentration. Now, you don't have to neutralize TCA, right?
Yeah.
Because it eventually self-neutralizes.
Correct.
But the clinical indicator that practitioners use to judge how deep the acid has burned is just wild to me. They look for something called frosting on the skin's surface.
Mm-hmm.
What is biologically happening to make a human face look frosted?
It's actually the visible coagulation of proteins, specifically keratin, in the skin.
Coagulation, like cooking.
Literally like cooking. When that highly concentrated TCA hits the epidermal cells, it physically denatures the proteins. Think of cracking a raw egg into a hot frying pan.
Okay.
The clear egg white rapidly turns stark white and opaque, right? Because the heat denatures the proteins. The TCA is doing the exact same thing chemically to the proteins in your face.
That is such a vivid image for a board exam.
Right. So when the clinician sees that white frosted appearance, it's their visual cue that they've successfully destroyed the epidermis and reached the upper layer of the dermis. After that, the patient experiences mild burning, followed by desquamation, which is just heavy peeling of the skin for about 5 to 7 days.
Okay, which sounds intense, but honestly, it's nothing compared to the deep peels. The guidelines discuss using TCA at 45 to 50% or using a chemical called phenol, and this is where that cardiac monitor comes in. Why does a cosmetic acid on the face threaten the heart?
Because phenol doesn't just burn the tissue locally, it's actually absorbed systemically right into the bloodstream.
Wait, really? It goes systemic.
Yeah, completely. And once it enters your blood, it has to travel to your liver to be detoxified and to your kidneys to be excreted. High concentrations of phenol can directly injure those organs, But crucially, it interferes with the electrical conduction pathways of the heart.
Meaning it triggers severe cardiac arrhythmias.
Exactly. You are quite literally taxing your major internal organs just to fix deep wrinkles on your face.
That's insane. And the formula detailed for these deep peels, known as the Baker-Gordon formula, it consists of 3 milliliters of liquid phenol, 2 milliliters of tap water.
Just so far.
Right. But then 8 drops of liquid soap and 3 drops of croton oil. Every single one of those ingredients obviously has to serve a specific mechanical purpose. So what on earth are soap and croton oil doing in a chemical peel?
Well, the liquid soap decreases the surface tension of the mixture.
Okay, why does that matter?
Think about dropping water on a freshly waxed car. It beads up, right? You absolutely do not want an intensely caustic acid beating up on the face. You'd leave some areas untouched and burn massive holes in others.
Ah, I see. So decreasing the surface tension makes it spread out.
Exactly. It ensures the liquid seeps completely evenly into every microscopic pore. Now, the croton oil, that acts as a vesicant.
A vesicant, meaning it induces blistering.
Yes. It severely compromises the skin barrier, which allows the phenol to aggressively drive down into the reticular dermis, that deep structural layer we talked about earlier.
And because it's driving so deep, the risk of severe complications like hyperpigmentation and hypopigmentation is massive. The text actually notes patients require pre-treatment for 4 to 6 weeks with topical tretinoin. How does pre-treating with tretinoin prevent those dark, erratic pigment patches?
So tretinoin is a powerful retinoid that accelerates cell turnover. When you inflict a traumatic burn on the skin, the melanocytes, the cells that produce pigment, they can go into a state of shock.
Like a defense mechanism.
Exactly. They rapidly overproduce melanin, causing dark patches. By pre-treating with tretinoin for over a month, you're systematically suppressing and stabilizing those melanocytes.
No, that makes perfect sense.
Yeah, and you're also thinning out the stratum corneum, the outermost layer of dead skin. That ensured when the phenol is finally applied, it penetrates uniformly, which really minimizes that risk of erratic post-inflammatory hyperpigmentation.
Okay, so chemical peels are clearly highly effective, but they rely on a chaotic fluid. You can't perfectly control exactly where a liquid acid seeps. If we want microscopic precision to avoid burning too deeply, we kind of have to abandon chemistry and move to physics, right? Lasers and mechanical abrasion.
Absolutely. When you need absolute measured precision, you move to light energy or mechanical force. So resurfacing lasers are divided into 2 primary categories for your exams: ablative and non-ablative.
Okay, let's break those down.
Ablative lasers, like your carbon dioxide and ERI-wave lasers, they target the water molecules inside the skin cells. They heat the water so rapidly that the cells essentially vaporize.
So they create an actual physical wound.
Right down into the dermal level, obliterating the tissue to erase deep lines, severe sun damage, all of that.
But non-ablative lasers take the opposite approach.
Yeah.
They heat the underlying dermis, but somehow they manage to leave the surface epidermis completely intact. How is a laser passing through the top of the skin without burning it, but cooking the layer underneath?
It relies on specific wavelengths of light. Those wavelengths basically bypass the surface tissue and are only absorbed deeper down. The biological goal of a non-ablative laser is collagen remodeling.
Tricking the body, essentially.
Exactly. By heating the dermis to a specific temperature, you trick the body into thinking it sustained a thermal injury. The fibroblasts, the cells that build structural tissue, they go into overdrive. Over the next few months, they lay down fresh, tight collagen to heal the quote-unquote injury.
Which pulls the skin taut from the inside out without ever breaking that protective surface barrier. Let's look at the face like an old, weathered wooden table. Ablative lasers and mechanical dermabrasion are essentially like taking a power sander to the table, right? You're violently stripping away the top layer to expose the fresh wood underneath.
That's a great analogy.
And non-ablative lasers are sort of like microwaving the wood from the inside out, changing the internal density without scratching the surface.
Yeah, and to push your power sander analogy into the clinical realm, the guidelines detail microdermabrasion. It relies entirely on physical friction.
Right, using an actual power-driven rotating handpiece.
With vacuum suction, it blasts microscopic crystals, usually sodium chloride or aluminum oxide, directly onto the skin to physically grind away that most superficial layer of dead skin cells.
And the text says this is highly advantageous for patients with darker skin tones, right?
Yes. For darker skin, the aggressive burning of a deep peel or an ablative laser carries an unacceptably high risk of causing permanent pigment changes. So microdermabrasion is much safer.
Going back to those ablative lasers for a second, if they're vaporizing tissue, and creating a confluent wound across the entire face. The recovery period must be just agonizing, not to mention the infection risks.
Historically, yes, it was brutal. But the clinical text highlights a really crucial technological advancement: fractional lasers.
Okay, fractional lasers.
Instead of delivering one massive solid beam of light that burns off an entire sheet of skin, the modern laser handpiece divides the energy into dozens of microscopic vertical columns.
So it basically punches tiny microscopic holes into the skin, but leaves actual bridges of healthy, untouched tissue between every single laser strike.
Precisely. By deliberately avoiding confluent damage, those untouched skin bridges act as immediate healing centers. The healthy cells rapidly migrate to close the microscopic wounds.
Which drops the recovery time from weeks down to days.
Exactly, and the overall complication rate just plummets.
Brilliant. Okay, so we've successfully resurfaced the canvas. But as the face ages, we don't just develop surface lines. We lose fat pads, our actual bone density decreases. You obviously can't power sand away a deep, sunken hollow in the cheek. We have to shift from removing damaged tissue to physically adding structural volume, which means injectable fillers.
Right, this is a fundamental paradigm shift in the rejuvenation process. Fillers are viscous compounds injected directly into the facial tissue to restore lost volume. The most common one you'll be tested on is hyaluronic acid.
But the rheology, like the physical flow and thickness characteristics of each filler, that differs wildly, doesn't it?
Oh, completely. Some are highly cross-linked, very thick and robust. Those are designed to be injected deep right against the bone to mimic a cheekbone. Others are soft, fluid, and highly flexible, designed to fill superficial fine lines around the lips without restricting movement.
Which is why understanding the exact anatomical plane of injection is so critical for residents. Let's look at the absolute worst-case scenario. Say a clinician is injecting a thick hyaluronic acid filler into the nasolabial fold and they miss the correct plane. What's the terrifying early complication detailed in the text?
Intravascular injection. The clinician accidentally pierces a facial artery and injects that thick filler gel directly inside the blood vessel.
Oh man.
Or, alternatively, they inject so much filler tightly around the outside of the vessel that the physical pressure just pinches it completely shut.
Either way, you have total vascular compromise. The arterial blood flow to that specific region of the face completely stops. So what is the immediate clinical sign in the chair, and what's the cascade of events if it isn't fixed immediately?
The very first sign is blanching. The skin over the affected area suddenly turns stark white because the oxygen-rich blood supply has been entirely cut off.
And if you don't reverse that ischemia,
If it's not reversed within hours, the cells will suffocate and die. The tissue turns necrotic, it turns black, slows off, and leaves severe, permanent facial deformity and scarring.
okay, so if a clinician sees that skin turn white, what is the exact emergency rescue protocol?
You must restore blood flow instantly. The protocol requires the aggressive application of warm gauze and topical nitrates, like a nitroglycerin paste,
Okay, why nitrates specifically?
because nitrates cause rapid vasodilation. They force the smooth muscle in the walls of the blood vessels to relax and open wide. You're basically hoping to allow blood to squeeze past the blockage.
Right.
And concurrently, if a hyaluronic acid filler was used, the clinician has to repeatedly inject large doses of an enzyme called hyalase directly into the area.
Because hyalase acts as a chemical scissor,
Right.
rapidly dissolving and dispersing the hyaluronic acid gel to clear the blockage before the tissue dies.
Exactly. It's an absolute emergency.
And that's just an early complication. The guidelines also outline these bizarre late complications that can strike months or even years after the injection. It highlights something called a foreign body granuloma, noting it might be linked to the formation of a biofilm. What on earth is a biofilm doing in facial tissue for years before causing a problem?
So, a biofilm is a highly organized microscopic community of bacteria. When the filler is injected, bacteria can sometimes adhere to the surface of the gel. They secrete this protective, sticky slime layer that essentially shields them from the body's immune system.
Wow.
Yeah, and it renders them highly resistant to standard antibiotics. They can sit entirely dormant in this walled-off state for years.
So the patient thinks the procedure was a total success, but there's just a dormant bacterial colony sitting on the filler deep in their cheek.
Exactly. And if something triggers those bacteria to become active, like maybe a systemic infection elsewhere in the body, the immune system suddenly detects this massive foreign entity.
And it just mounts an aggressive attack.
Right, walling off the infected filler with inflammatory cells, creating a hard, painful, visible nodule under the skin. It's a severe inflammatory response to a foreign substance.
Incredible. Okay, so we fixed the surface canvas and restored structural volume. The final step in this clinical text is addressing the mechanical movements. We have to stop the muscles from folding the skin and causing the dynamic wrinkles in the first place. So we've reached the most widely administered cosmetic treatment in the world, botulinum toxin.
Right, commonly known by brand names like Botox. This is a highly potent neurotoxin produced by strains of the bacteria Clostridium botulinum. There are 8 known exotoxins in existence, labeled A through G, but type A is the absolute workhorse of the cosmetic industry.
Let's examine the cellular biology of how this toxin actually stops a muscle from moving. For the exams, the clinical guidelines state that the type A toxin molecule consists of a heavy chain and a light chain.
Yes, when injected into the target muscle, the heavy chain binds specifically to the presynaptic neuronal cell membrane.
Right at the neuromuscular junction.
Yeah. Exactly, that exact gap where the nerve communicates with the muscle. The heavy chain acts as a key, picking the lock to trigger endocytosis, which is the process where the nerve cell swallows the toxin whole.
Okay, and once it's inside?
Once internalized, the light chain breaks off. This light chain acts as metalloprotease, a highly destructive enzyme. It hunts down and violently cleaves a very specific protein inside the nerve ending called SNAT25.
Okay, so think of SNP25 as the loading dock at a biological warehouse. Under normal circumstances, the nerve cell brings little chemical packages of a neurotransmitter called acetylcholine down to the dock, ships them across the gap, and tells the muscle to contract. The Botox light chain essentially blows up the loading dock.
That's a perfect way to visualize it.
The nerve is still firing, it's actively trying to send the command, but it has no physical infrastructure left to ship the packages, so the signal never crosses the gap.
Right, because that chemical connection is completely severed, the muscle doesn't die. It just becomes entirely deaf to the brain's commands. It can't physically contract, so the skin above it stops repeatedly folding, allowing the wrinkle to smooth out over time.
And this biological sabotage takes time, right? It takes 24 to 72 hours to start taking effect, peaking at around 7 to 10 days. But the duration of the paralysis, which is usually 8 to 12 weeks, that isn't because the toxin eventually wears off or degrades.
No, not at all. The duration is dictated entirely by neuroplasticity. 8 to 12 weeks is exactly how long it takes for the human body to physically grow brand new nerve sprouts from the axon, build an entirely new loading dock, and reestablish a fresh synaptic contact with the muscle.
Your body literally wires its way around the chemical damage. Because we are dealing with a profoundly potent biological toxin, the way the clinical dosage is calculated is hard to believe. The dose of Botox isn't measured in standard milligrams. It's expressed in quote-unquote units of biological activity. 1 unit corresponds to the median lethal dose, the LD50, in an 18 to 20 gram female Swiss Webster mouse.
Which really highlights the extreme lethality of the substance. They can only measure its clinical potency by calculating its exact lethality in a standardized laboratory animal.
And the guidelines note that based on primate studies, the estimated lethal dose for a 70 kilogram human is 3,000 units. A standard clinical vial of Botox contains 100 units, so you would have to intravenously inject 30 full vials to reach that lethal threshold. The manufacturer's maximum recommended dose is 360 units in a 3-month period. It's a carefully calibrated tightrope walk.
Which is precisely why the medical regulations governing its use are so incredibly stringent. The text highlights the General Medical Council's rules in the UK. Even though it's the most common cosmetic treatment globally, much of its use for wrinkle reduction is actually quote-unquote off-license. The GMC explicitly mandates that prescribing these injectable cosmetic products must only occur after a physical, face-to-face examination of the patient. There are absolutely no telephone, video link, or online prescriptions allowed.
You cannot order a localized paralytic over Zoom.
Exactly. It requires profound anatomical knowledge to ensure the toxin stays exactly where intended. If the toxin migrates or is inadvertently injected into an adjacent muscle group, the complications are highly visible and physically impairing.
Like what?
Well, if it hits the levator muscle of the upper eyelid, you get blepharoptosis, a severe, uncontrollable drooping of the eyelid. If you're injecting around the lower face and hit the wrong muscles, you can cause excessive drooling or dysphagia, which is an inability to safely swallow food or liquids.
And this is exactly why clinicians aggressively warn patients never to massage their face after receiving injections. You do not want to physically rub the unbound toxin over into the wrong muscle group while it's still trying to pick the lock on the cell membrane.
Right. It's a highly localized, precisely targeted paralysis. But even when executed flawlessly, the guidelines detail a phenomenon known as therapeutic failure. Up to 15% of patients who receive repeated long-term injections of Botox simply stop responding to the treatment
Wait, why does the paralysis just stop working?
because their bodies begin producing neutralizing antibodies against the toxin. The immune system finally recognizes the biological invader and destroys the light chain before it can ever reach the loading dock.
Oh, wow.
Yeah, and when that secondary non-responsiveness occurs, clinicians are forced to switch the patient to a type B botulinum toxin. Type B evades those specific antibodies and sneaks in to cleave a completely different protein called synaptobrevin to achieve the same muscular paralysis.
So as we continually chase aesthetic perfection, tweaking our faces with these carefully calibrated toxins, we are literally forcing our own immune systems to adapt, evolve, and fight off our beauty treatments. We're essentially locked in a biological arms race with our own vanity.
Yeah.
The X-ray might not show the damage, but the body remembers.
It really does.
Now, if you are a plastic surgery resident preparing for your board exams, or you simply want to master the key clinical facts of surgical and non-surgical aesthetics, head to medsynclimited.com and get the FRCS Plastic Surgery Anki Deck with over 6,000 questions arranged by topic to help you recall the key facts. It's based directly on the textbook Keynotes in Plastic Surgery.
And be sure to press follow on the show to listen to more episodes, rate it if you learned something today, and please leave a comment or question.
We will see you on the next deep dive.